We'll go ahead and kick things off with just a quick round of introductions. So if you wouldn't mind starting to introduce yourself, and then we'll go down the panel.
For sure.
Oh, yes, go ahead. Thank you.
Yeah, so I'm Griffin.Bond. I'm a person in long-term recovery myself, but I'm the executive director for Evolve Addiction Treatment at our Prosperity Point location, which is off of Cedar Bluff here in Knoxville. It's a 110 bed residential halfway house where we provide sober living and partial hospitalization, intensive outpatient, and OP and MAT services to our clients.
I'm Dr. Hilary.Parker. I am the Director of Integrated Substance Use Disorders at River Valley Health, formerly Cherokee Health. We have clinic locations kind of all over East Tennessee, and primarily provide things like we do have outpatient groups, but not a formal IOP. We have addiction medicine services. We have behavioral health services, primary care services at a range of locations and accessibility.
I'm Lisa Harris. I'm the clinical director at Susanna's house, which is an intensive outpatient program for pregnant and parenting mothers. We also have childcare and some supportive recovery housing.
And I'm Kayla Smith, and I'm with McNabb Center, and I am the services coordinator over our special or co-occurring specialty programming. So mostly our IOPs, recovery housing, and some other collaborations.
And I'm Cody.Young, so I do business development at East Tennessee Behavioral Health. So we're a 90-bed inpatient psych hospital that does acute stabilization and inpatient care. And then our outpatient service lines that we offer is IOP, PHP, and ECT.
Well, thank you all for being here for our outpatient SUD services panel. We'll go ahead and kick things off with our first question, which is about qualifying. So if you have anything to add, feel free to just go ahead and share your 2 cents. Now, the first question that we want to ask is, what factors qualify someone for outpatient substance use disorder services?
This is just in general to everyone.
Yeah, in general, and then also if your agency has something specific, feel free to also add that.
Well, I'll say something. So right now we have like a screening line that we have that people are calling into, and we're doing kind of a screening form. And really that's just to determine if they possibly need detox services. So, if they're actively using alcohol, benzos, or heavy amounts of opiates or other substances, and they're going to struggle with coming off of them, then we want them to do that safely, and we would refer to detox and then step down to us. But if they're kind of not a daily or kind of trying to wean themselves down, then we can start them into IOP. And right now we've transitioned into an open access way to get into treatment. So those slots are Monday through Thursday at 10 o'clock. So people can just walk in and get assessed. And then we're able to kind of see, either put them towards MAT, IOP, or if we need to refer them over to detox, we're trying to do that so that there's not such a wait for people to get help, because we know they're in the mindset right then and there. So we want to try to snatch it when we can. Anyone else have anything to add to that?
Anybody that is wanting to access substance use disorder services is eligible for outpatient substance use disorder services. But I mean, certainly we could refer folks to a higher level of care and safe management. But I think anybody that's willing to engage in services, and especially being at the outpatient level and creating that access point, we have some walk-in centers now that are up and running in around the Knoxville area. We just opened our Mechanicsville office, which has walk-in primary care and behavioral health services daily. And our Get Well Now clinic at our Western Avenue location also has walk-in primary care services, and they can access behavioral health service lines. We are trying to streamline kind of our new patient process referrals to specific to substance use services in our outpatient clinics. They can call our new patient access line and hopefully get connected to somebody a little closer to one of our clinics who can schedule them a touch point with someone on our team relatively soon. But yeah, I think anybody that is seeking that support, we want to kind of meet them at that outpatient level and figure out how to develop a plan around that. It involves pretty much everybody on this panel.
Yeah.
Okay, thank you. So then, given that information, how is it determined whether outpatient care specifically is the right level of treatment for an individual?
We use the American Society of Addiction Medicine criteria
ASAM.
as part of the assessment that we do. So it's a pretty detailed assessment, and at the end of the assessment, the ASAM is part of that, which gives the criteria. And for each of the criteria, you assess that particular person, where are they in that? And that'll pretty much give you where they need to be. And of course, the clinical judgment in as far as do they need detox and what they've already mentioned.
I think everyone might know we use ASAM as well. Kind of the standard of practice,
Yeah.
I would say.
Yeah, I mean, generally, we're
Best practice.
generally just trying to prioritize patient safety. It's the safest level of care that they need at this moment in time. There certainly, and you already spoke to this, the number of substances that where withdrawal is potentially fatal, and primarily wanting to make sure that we get people appropriate care.
Partially too, we want to set them up for success. So if we know that it's going to be a struggle for them to come off, we're going to try to refer them to detox first so that they can start fresh. Otherwise, sometimes if they just come into IOP, it's not enough. And so it could be detrimental to them.
A lot of it too is just patient willingness. What level of care are they willing to access? And sometimes we get started at a particular level of care and we make changes, but at least in that case, they are engaged and involved with the larger care team, and we have more resources to support them through kind of whatever process they're needing at that point. So willingness to access to care. We also talk a lot about kind of what they've tried and what they're willing to try, maybe try again, and what resources they have to support them.
That's what we do. So our facility operates on a direct referral basis. And then we also accept walk-ins 24/7. So if somebody does a walk-in, we'll do a complimentary face-to-face assessment with one of our admissions counselors. And Acadia Healthcare, which is who I technically work for in this market, we're a joint venture with Covenant Health. It's an Acadia standard that all of our admissions team has to have at minimum, they're a master's level social worker. So they're getting a good assessment. And at that point, like what we all do is we look to see, does that individual need inpatient? If they don't need inpatient, then would it be appropriate for IOP or PHP? And then if they're kind of not at any of those three levels, and that's when we work with like Evolve and Helen Ross and well, no, you're not Cherokee. I was going to say Cherokee.
River
but
Valley.
River Valley.
We're all
and
getting
get
used
them-
to it.
Yeah, and get them situated somewhere else. And then if we have an adult that needs inpatient that has a co-occurring SUD, then we can actually detox them while they're at the hospital. So we can go ahead and get that ball rolling as long as, it's safe. Because like you mentioned, there's a lot of times with DTs and benzos and, that it can be, unsafe to keep them there. So we would get them additional like medical clearance through an ER, just make sure they're okay. And then we'd get them back and start that.
Thank you, everyone. So in hearing from the community about some of the questions that they have, it was pretty clear that there was a trend in not really understanding what each level of care looks like, including outpatient services. So could you walk through what services or supports are typically provided in an outpatient program? And it could be generally speaking, or if you have specifics you want to add from your agency, you're welcome to as well.
Yeah, I know at Evolve, when somebody admits into our program, our clinicians, will provide, we do acceptance and commitment therapy, DBT, CBT, but also we provide case management as well. So we may help them navigate legal issues, whether that be with DCS, referral sources, things like that. We also help them with some administration issues, right? Getting vital documents back. How do you obtain a birth certificate or an ID as well? And then also we partner with other organizations that, teach them financial literacy, teach them about nutritional health, to really get them set up to provide them the best, all the information they would need to try to live a healthy lifestyle. And then what's cool at Evolve, since we provide that licensed supportive living, is that not only can they receive this treatment in our office, but then we could hold them accountable to that outside. of the typical hours of outpatient treatment, right? Is really support them in real time in an atmosphere of recovery in a community that will help lift them up, and maintain those different treatments that we're implementing in their process.
Yeah, River Valley is exclusively an outpatient treatment center. We don't have any inpatient settings. I have to collaborate with some of the wonderful colleagues on this panel when folks need that higher level of care. From an outpatient service perspective, River Valley is an integrated primary care center kind of to start. And so you can access things like primary medical care, behavioral health services ranging from traditional therapy to kind of integrated behavioral health specialist, psychiatric care and consultation. We have certified peer recovery specialists that collaborate with our clinics. We do have an addiction medicine program that is growing. It's in primarily in our Western Avenue location here in Knoxville, but we've kind of grown and expanded to other outlying clinics, some of our rural offices. And through that, you really have access to the whole team. We have some employment specialists, we have peer wellness folks, we have some community health coordinators. And so we're trying to give kind of as much access to as many services as we possibly can. We do have some group therapy programs. And so outpatient services really, it's kind of a collaborative process of building your team. Again, kind of what you're willing, what you're wanting to engage in, what supports you're needing. But we would really kind of give as much support as possible for both that kind of lifestyle change, outpatient support, especially the aftercare planning. When you come from any one of these kind of amazing centers, but what do we do now? Aspect of care, we're really looking at what do we do now? What do we do at this level? What do we do when you're home? And so that's where we pick up. You guys do all the hard work, inpatient.
I think one of the things it's so important, and it's been mentioned some, is just the wraparound services, the case management, the helping with court, and the getting my driver's license, and how do I pay these fines, and all that sort of thing. And then as they get toward the end of the program, we're also looking at housing and transportation and all those kind of issues that can just bring you down if you're out there and you've got kids and you're trying to provide for them and that sort of thing. So our program, not only are we working diligently on their recovery and how to do that, but also on how do I live as a mom in Knox County and have what my kids need and have what I need and that sort of thing. So it's really a real holistic approach. And we have the intensive outpatient program, and then we also have as our aftercare program, just outpatient therapy with a licensed therapist and group meetings once a week. So we have both. I think that they really seem to appreciate that because it keeps them connected.
I think kind of like what everyone said, it's really kind of a continuum or a spectrum to kind of get all of the services, and that's kind of where we're trying to evolve to. And so, our IOP, it's 4 days a week. We have integrated case management. Actually, Miss Joni here is our case manager with our IOPs. So she can work with folks to help with those things, as documents, that transportation part, that kind of getting them set up for success. So we make sure that there's no barriers, so that when they do discharge or step down, that they do have things in place to be successful. That is also part of why we have moved to the open access or walk-in. So it's easily accessible, and we can kind of refer them to the program that may be, best suited for them. We also have a intensive case management for folks with opiate addiction that need more support, more help in those different areas, which a lot of those folks we found have a lot of medical concerns and are just a lot more complex of cases. We have our MAT program, so we're able to work hand in hand with them when they're in IOP, or if they're in IOP and they, are struggling or have a bad lapse, then we can refer to other services. So with the recovery home, that's kind of the last piece of our full continuum of services. But yeah, it's treating them at all levels and just making sure they have the plan or the help and access. And then we also have our mental health services across the building. So we definitely make referrals over there. in our IPS workforce as well. We work with them a lot to try to help get them jobs and get them some income to be able to have housing. It's, you know, the domino effect, making sure all those pieces are in place so everything works out and it doesn't create any barriers for them.
So for us, so our inpatient side of things, we can take care of adults. So we have an adult unit and get them stabilized. If they have a co-occurring disorder, we do manage the detox while they're there. We also have an adolescent unit for 13 to 18-year-olds. Because unfortunately, you know, that's a rising issue as well. Then if we have an individual in the community 65 or older that needs geri psych or senior behavioral health services, we have a unit for that as well. As far as the inpatient stay goes, what we do is we have a collaborative approach. So if we're getting that individual from, you know, Evolve or another facility, we're going to work with them to figure out what's best for that patient. So everything we do, it's not cookie cutter, it's individualized and tailored to what that patient needs. So we want to meet them where they're at. Not too far backwards, not too far forwards. While they're inpatient, everything's structured, it's scheduled. Our facility has a gymnasium. So if the weather is kind of rough, they're not just stuck, you know, inside all day doing nothing physical. We can actually take the patients to the gym and they're engaged with the OT people down there doing activities. Our facility has a standard where we have nutritionists on staff because we know that nutrition ties in with mental health. So we're going over their diets and getting them with a good plan for that to help them. They're learning, you know, coping skills. There's journaling. We have music therapy, art therapy. And as far as when discharge approaches, that's when our discharge team, which is comprised of case managers and social workers, get involved. So we're looking at what they need for aftercare. And the options that we have for stepping down from inpatient would be the partial hospitalization or the intensive outpatient. So if they need one of those, then we'll get them set up. Our IOP has a virtual and an in-person option, but we don't silo the patient into one. So if they want to do virtual, then one day they, you know, just want to come in and have that face-to-face kind of appointment. All they have to do is call ahead and we'll schedule them to face-to-face, or they can just maintain virtually. And that meets 3 days a week for 3 hours a day. And it has morning and afternoon. That way it kind of works around their schedule. And then our partial hospitalization would be 5 days a week. And they get there at like 9 in the morning and then they stay till like 2:30, or they can stay later if they just need like either 6 hours or 8 hours. And that's going to be designed for somebody that needs that care of inpatient, but you know, can go home in the evening to just kind of recover and relax. So they still get all of the therapies and modalities as inpatient. So it doesn't cut them off, but we deal more with kind of like some motivational life skills training in addition to that. And then like everyone up here, we do the CBT and the DBT therapies and family, group, individual. We'll do med management if they're fully enrolled in either of those two programs. And then we also offer ECT. So we're the only facility in this area that actually has outpatient ECT.
Can you say what ECT is?
So that is electroconvulsive therapy. So basically, that is a last ditch effort for somebody that has tried all the therapy, all the medications, anything you can do to treat like bipolar disorder, schizophrenia, chronic depression. They're suicidal and they've had several attempts, but you're not breaking through. So what we do, which we have anesthesia involved and do administer some sedatives, is that physician will put like a little hairnet thing with electrodes on their head. And then depending on what we're treating, and where they are in that treatment schedule, there's a certain voltage of electricity that's used. So they kick on the machine, it delivers an electric shock and stimulation to a certain area of the brain, and it basically creates a seizure. So we have a medically induced seizure for a certain amount of time, and then they turn the machine off. And then I've seen it, work miracles. It's a little scary sounding, but when I've kind of followed along and done some case studies with patients we've had that, were 19, 20 years old and had 4 or 5 suicide attempts, that they were almost, unfortunately, they were almost successful at them. And the parents, brought them in and we did the treatment, and it was, a complete 180. And that just depends. So usually in the beginning of that treatment, you're usually doing it like 3 days a week, and it's all done as outpatient. And then from there, it would taper down into maybe 1 or 2 days a week, and then maybe a couple times a month. And then you'll go into a maintenance phase, which could be once a month, once every 3 months, once a year. So it just depends on kind of how they're responding. So it's pretty interesting.
Very interesting. Thank you, everyone.
Mhm.
When I explain it to patients, I draw a picture, and this is not going to translate very well for the audio only folks, but like when I talk about levels of care, I talk about like getting to their point, and it's a lot of subtraction. So like the higher you go, the less you are trying to manage yourself, right? So like you subtract everything. Like you go to this inpatient center and you are solely focused on you and your health and your safety and coming off of the substance, right? Like we've subtracted work, bills, or other roles, other responsibilities, other things that you're dealing with necessarily. And we've really tried to get to this point of like maximum care for you. And so that's like the peak of their triangle. And our triangle works in the inverse, right? So like this is our base. This is the most services you can get. When you're at your point, we're at our base. And so we're giving you the most services possible. You're at an inpatient center, you're going to groups, you're meeting doctors, you're meeting therapists, you're meeting recovery specialists. Like this is the maximum amount of services we're going to try to offer you when you're at your point, when you're dealing with less. And what happens over time is as you we'll go through the different levels of care, you're expanding your support systems, you're going to PHP, you're going to residential housing, you might be adding back work, you might be adding back other responsibilities, and you're adding over time. And as you get to the outpatient sector, our service band narrows some, not like just cuts you off, but narrows to meet your needs and to allow you to balance some of the things that you're kind of adding back into your triangle. So maybe you're in addiction medicine and maybe you're meeting with us weekly or biweekly and then eventually monthly, and you're meeting with peer support and behavioral health and psychiatry. And eventually you kind of cull down your care team as you're expanding your recovery supports and family connections. And again, kind of roles, responsibilities, things that you're doing. And so that I just tell them to think about it in that way. Like this is the highest point with most amount of services. And eventually we're going to kind of balance this out. You're going to expand your support system, your community supports, your family supports, your recovery supports, and you're going to need kind of less and less and less services in order to balance some of that all together.
Love that visual. That's very good.
Explanation.
That's great.
I draw it on our exam room tables. Sorry for the audio only folks.
Picture triangle.
Picture some triangles.
And then just one very specific question about services offered. Lisa, since you work with mothers, including expectant mothers, could you speak to maybe what kind of differences there are or more specific elements that are available at Susannah's house for your clients?
Well, one of the big things is we don't charge anything for our services and they don't have to have insurance. So that opens it up to a lot of folks who might not otherwise get treatment. But we start at any point in their pregnancy. I know a lot of places, if you get to a certain number of weeks, then you can't be in that program at all. We're pretty much open from day one till they have the baby and then some. We work real closely with like High Rock and Fort Sanders and those folks to get them to their appointments, to make sure they got plenty of prenatal care and all of that. And also after the baby is born, to make sure mom and baby get to those appointments so that they're getting the medical care they need as well as everything else. Our program is very much based on being a parent. So we have parenting classes every week. We have prenatal classes, we have infant care classes, we have all of that sort of thing to go along with their recovery skills and their 12-step work and all of that. We work a lot on things like nutrition and which is huge. Not only what do I need to eat, but what do I need to feed my child and those sorts of things. We do have some supportive recovery housing for a mom and one baby. So we can help them be even more safe. And that way we get a lot of calls from the hospital saying, I just had a baby and I've got no place to go and they're going to take my baby if I don't go somewhere. So that's something that's, that we can offer when we have space. That's truly, just a blessing. And then we also offer childcare because all of our clients are moms and many of them have custody of their children. So we offer trauma-informed childcare and we work with the kids as well. We have 2 therapists who work specifically with children. So we do assessments on the kids and do some play therapy and social skills training and developmental work and that sort of thing with the kids as well. So it's a little different approach than a lot of places that are, strictly doing substance use or co-occurring services.
Thank you. So beyond the services themselves, we've seen that families in particular who have a loved one entering outpatient services aren't entirely clear on what's expected of them. Like maybe they understand what their loved one is going to need to do, but then where they step in to support is kind of a really big mystery to them until they kind of hit the experiences right then and there. So could you speak to what individuals and families should expect at the beginning of their outpatient treatment, not just for them as the patient or the client, but also their loved ones who might be part of that support system?
Big question.
For us, one of the concerns with that is that so many of our moms don't have a support system. They don't have a family who is either supportive or they don't have enough family members who are clean and sober to be helpful for them. So a lot of times we're dealing with all the family trauma in addition to the personal trauma that the clients come in with. But we will do, if we can, if there are folks involved, we will do some couples work and we also do some family work if we have parents or older children or that sort of thing that are involved, and we try to get them involved if it's appropriate.
I think we try to recognize and really validate that sometimes recovery almost creates like a new kind of burden for families and caregivers. Sometimes we'll run into families or spouses who've been maintaining, and they've been maintaining alone with an individual that's really struggling. And now they're maintaining, again, kind of alone with a person that's also really vulnerable and a person that now has really frequent appointments and lots of visits per week and needs transportation and needs kind of accountability to some of the things that they're doing. And so we've almost kind of increased like the number of things that we're asking them to do, but we try to do that with even more support. So we're trying to do that and making sure that that this individual has the support of therapy, has the support of case management, has the support of peer support. We can help you with transportation options. And so we're trying to say like, hey, we recognize that we've added more and we've added more people as well to support you, that this is no longer something that you have to deal with in isolation. Definitely encourage them also and offer and fold them into some of their own support if we can. But I think just sort of recognizing that like there's a difference between just kind of maintaining your life when you are also supporting someone in addiction and maintaining your life when you're also supporting someone in recovery. And it's just important to hear that and to know that and provide as much support.
Y'all covered it pretty good. I think the only thing is sometimes educating clients that sometimes the support they have isn't the best support. If, they're going back to the same environment they left from, things like that. So sometimes it's almost just educating them on what a good support system is, or helping them realize that sometimes the relationships they have are not healthy, and trying to find them a positive support network.
It's multidisciplinary, multifaceted support.
Yeah.
So it just starts from the beginning, having that conversation with the therapist and figuring out what road to go down. And then just making sure that you help them navigate it and be there for them. And that's why it's nice for all of us, up here, we all collaborate together. So there's, there's a lot of resources and places available. It's just why it's important we do more things like this so we know what's out there, who can do what.
Well, programs change so often and
Mhm.
adapt and evolve, and so
Yeah.
it's they're knowing about the changes or who the contact person is, or those types of things.
Yeah, or just the payer source.
Yeah.
Like, we had that conversation up here earlier. It's like, oh, you take Ambetter. Oh, you do, like, that's why it would be neat to have just, a one-stop shop of information, like a database to access.
It's
Because,
constantly updated.
Yeah.
Because part of it is we'll put a resource guide together, and within a month it's outdated.
yeah, so just ever evolving. But just making sure, like we've all said, when that patient is motivated enough to want that help, that you get them going, because you don't want to miss that opportunity, because you never know when it's going to come back around.
Mhm.
And then if they've struggled for years and there was a catalyst that finally makes them reach out, if it's not easy for them to navigate and there's no support and you're calling phone numbers that nobody answers, then they're not going to try to get better anymore. They're just going to go right back.
Now, we also recognize that sometimes there just isn't an immediate opening available for treatment, for outpatient treatment. And so our next question is talking about or addressing more so what to do when someone finds themselves or their loved one in that situation. So Griffin, if you wouldn't mind starting us off, what options are available to individuals and families if there is a waiting list for the outpatient service that they're looking at?
I mean, in my experience with that, I would say just call, right? And usually, I know I can speak for us at Bradford and Evolve, right? If there ever was a waiting list or limited availability, we're going to try to contact somebody else who has that bed. We're going to advocate for that client. So I would just say keep trying, because I know, we have 110 bed capacity at Prosperity Point, but we could actually do IOP from home. We offer virtual services. So there's usually some sort of resource available to meet that person where they're at, to at least bridge that gap until we can, like Cody was saying, catch them in that moment of willingness, that opportunity to reach this person and try to bridge that gap to where they're in a seat, where they want to be with that level of care. That's what, I know all of us up here probably work with other referral sources to ensure that, hey, that person is placed in the level of care they're seeking for in the immediate future. He at an organization like Bradford, that's something I don't come across a lot as a waiting list for us at Evolve. But somebody who does experience that, I would just keep calling.
Any other thoughts?
That's kind of why we transitioned to an open access, because we were having that issue of, oh my gosh, well, we can't get you an appointment for 3 weeks. And then they're not in that headspace anymore. We had so many no-shows showing up for intake appointments, and it just wasn't going well. So we have adapted. And so like right now our men's IOP group is full, but we have started a supplemental like recovery skills or recovery support group as an interim service for them to be able to get into IOP, so that we can get them engaged, and kind of get them hopefully that support until they're able to move into like the full group. Another thing is, I'm sure most of you know Centerpoint's expanding. They're pretty much doubling their capacity, and they're going to have between 60 and 70 beds, I believe. And then we're going to be expanding some insurance options as well that they'll be able to take private as well. So just working with our fellow service providers and being able to provide referrals. Like we've gotten lots of referrals over to Evolve, or if we find out like they have Ambetter or Medicare, then we try to help them navigate. We just don't tell them no and hang up the phone. We have a resource list, and that's part of what that screening line is for, to make sure that we can get them in the right direction and they're not just coming kind of wasting time that we can't serve them. But we get a lot because we take the uninsured, which so many others don't for those IOP services. So we've been slammed with court lately. Yeah.
I think in terms of access, we're just trying to connect to someone.
Yeah.
It may, I always tell folks like cast a wide net when you call us. Like
Mhm.
it may be that this service takes some time to get into, but like, let's just see if we can get you talking to somebody.
Mhm.
Somebody who can praise you for making this call, somebody who can support you, somebody who can call you again next week, somebody who can start to address kind of the myriad of other things that surround this. Whether that's a behavioral health provider, a primary care doctor, what can we offer you kind of in this moment now? How can we make you more safe now? And just generally kind of like who can we get you to talk to quickest and see if that, and that way we're just kind of folding you into those services and hopefully branching out from there.
Yeah, and that's, I mean, that's what we do. Like we've all talked about, like we get patients from Evolve, like all the time. Cornerstone, Stepping Stone, like all of that. Like so we all collaborate with each other and kind of know what each other has. What we do is like Acadia Healthcare, we're the largest behavioral health company in the United States. Like we have stuff everywhere. So we have a protocol or a process. If we were to experience a waiting list, which like that's kind of why virtual is such a hot thing right now, because a lot of organizations have found if you do it virtually, if your room only holds 10 people, now you can maybe bump it to 15 because you're in a virtual room. But we will cross-refer to not only our partners in the community, but to other Acadia facilities as well. So like Erlanger, for instance, that's our sister hospital. They have virtual IOP. Somebody obviously doesn't want to drive 2.5 hours, but if they were, in a pickle, we could at least get them, set up with that, and they could at least get something going, until something closer to home opens up. So.
Thank you. Then before we open it up to the audience for additional questions, the last question that we prepared is, how can people stay safe and supported while they're waiting for an opening, either for your specific IOP or maybe another service that they might be a better fit for?
I think kind of like what you said, like connecting them to someone, like finding somewhere to start, whether it be giving them AANA resources or connecting them with a therapist or a case manager, or coming to MDC and getting some support here. Just kind of picking everything, throwing it at the wall, see what sticks. Like give them options, and just kind of know what's available. But it sounds like the majority try to get people in pretty quickly or adapt to be able to get them something, so they aren't just sitting waiting.
Because I get it's been a while since it's happened, but like my phone number, everybody has my phone number. Like I get calls from people I've never met that are in crisis, and the blessing about traveling all of East Tennessee is I meet everybody. Like I have business cards, like bags of business cards and notes. That way, if I get a phone call, from somebody that needs help, I try to steer them to what we have if we can, just because it's a little easier to manage. But, if we have, I got a call one time from an ER that had a nonverbal autistic 18-year-old that they had in their ER for like 2 weeks. And they called me and they're like, hey, we know, you can't help him because, it's outside of our scope, but we don't know who else to call. But I was able to get a hold of, which most of you probably know, LaDonna. She does business development at Pitt Village, and she's done it for years. Like she knows everybody. So I called LaDonna. LaDonna sent me, she emailed me a giant Excel spreadsheet of stuff. And I got it down to the ER staff, and 2 days later, they had that kid placed. Yeah. So I think ultimately, as long as people that are in this role, for whatever your role is, whatever organization you work for, if you inherently just try to do the best you can, and support those people, I think that goes a long way with keeping them safe, and just trying to do something. Just be like, it may be a few minutes, but I'll call you back, and just make sure that you call those people back, because I've had people wait a little bit, but as long as they know somebody truly cares and they're actually going to help them, I think that goes a long way in keeping them safe, because you could keep them from escalating to a worse point than where they're at.
Well, I think something positive about just Knoxville in general is I feel like we have so many events like this, or events and networking, that everyone kind of has the mindset of let's do what's best for the client. So if I can't help them, let's find another provider that can, or let me reach out, just like what you said. I don't have a clue, but let me reach out to someone I know.
I know a guy.
And be able to do that. So I feel like the network that everyone has developed has been really helpful to get them some sort of assistance, especially in odd situations like that, because sometimes you feel like you hit a brick wall.
Thank you, everyone. I'm going to go ahead and open it up. Are there any questions from the audience at this time? Yes, go ahead. And if you wouldn't mind making sure you speak up, so, well, I'm going to attempt to pick you up. We'll see how that goes.
I just had a quick question. Are there any limitations to working with the different agencies? Like sometimes when clients, I've heard in other places, if the client is working with one particular organization, sometimes that may limit them from receiving services at another. Is that the case?
The other thing I'd say, we can't duplicate services, so it can't be the same service, but they could go to River Valley Health for their medication.
Totally, Cherokee.
They could come to IOP with us. Any of those things, or we've had clients that are in our SOAR program or our opiate abatement council case management, and they were at Evolve. So it's just as long as the duplication, it's not a duplication of the same service for us anyways.
Some of the limitations are payer driven too. It's not like the duplication of services, but also like behavioral health safety net. You can only use with one mental health organization. And so you may be utilizing your behavioral health safety net with one, but also potentially seeking services elsewhere that may bump into a different category of who pays for this, whether it's self-pay or another grant or another option. And so sometimes there are sort of complexities of that, which we try really hard to navigate. It's not something that we impose, but it's more so kind of like
Powers that be.
the powers that be and kind of what they dictate in terms of who can put coverage where.
Yeah, because you can't really, I guess, double dip would be.
Mhm, yeah.
Yeah, and
Yeah.
most of the roadblocks is payer source, like Medicare, for instance. They only give you so many days
Mhm.
for, it's like back in the prepaid phone days, like when you were out of minutes, you were out of minutes. So that's where we kind of see issues that limit somebody from coming in, and just, you got to be a network with them. Insurance is king, unfortunately.
Mhm.
But, we try to know what everyone has, and if we don't have it and it's not going to be the absolute best thing for that patient, then that's when we're all going to get him somewhere that's going to be a better fit.
I would say at Evolve too, it's important to note that we offer sober living and outpatient treatment, but our sober living is contingent on you being in our outpatient program. So we might have people come to our outpatient program from home and not in our sober house. And also, we have clients who might work with another mental health provider or MAT provider, but in order to be in our licensed halfway house, you have to be. But we do work with other sober living entities in the community too.
Okay, so let me make sure I heard that correctly. So if you live in sober living, you have to use your outpatient services.
At Evolve.
At Evolve.
All right, yeah.
But if you live in the community, you can still use the outpatient
Yes.
services at Evolve. Okay.
Yep.
I just want to make sure I heard that correctly.
Yeah, no, thank you.
The other question? I did get one question that just came in. Someone was wondering if I have a loved one who has heard about outpatient care from a friend and saw how successful it was for them, and they're very, very set on that level of care. How does one go through that experience where, as providers, you talk with them during the assessment, you find out it might not actually be the best level of care for them, How do you redirect someone to see the benefits of another service of care if they are very, very set on just the one that you provide? I don't know if anyone's experienced that yet.
It's kind of using her pyramid type discussion of like, we have to, your friend had a great experience. That's awesome. Let's make sure you do too. But let's figure out what's going to be best for you, and trying to really tailor and personalize it for that individual and kind of explaining why they fit criteria for this, that, and the other. I mean, sometimes we can do, it's just hard, especially with like meeting ASAM criteria. But it's also trying to meet the needs of the client. So it can be tough, but usually they're pretty adaptable. The only thing that we have issues with is if we recommend residential. A lot of times they don't. They just want to do IOP, which as long as they don't have to detox, we can try them in IOP. And we always, say like, if you continue to struggle, we may have to refer you to a higher level of care. It's kind of how we would do that.
I think in some ways too, you just have to be willing to hear the barriers, right? Like, and that's where the wraparound services come in handy. Like when you're sitting across from someone who, and this like happens to me plenty. Like I'm recommending like, you really need to go to the ER. Like this is really, you need a higher level of care. You need some stabilization, you need some medical support. This is what's safest for you. And they've got 3 kids at home and a day out of work because they're gonna send the ER for hours, and a day out of work means no income, means a bill that doesn't get paid, means less food this month, means the rent is even more behind, means like their spouse that is going to sit with them is also going to miss that day of work. And like how do we then address some of those concerns that may be the barrier to accessing the care that you need? And just by like hearing and validating and acknowledging like all of these things exist, and this is still the safest, like most important, kind of most recommended level of care that I can give you at this point, and a lot of those conversations are hard. And sometimes you meet a patient exactly where they're at and exactly where they're willing to engage, and you go on and it is just not the most successful treatment for them. And you're watching this process and you're just being really open and direct about this process with them. How's it feeling for you? Here's what we're kind of looking at and seeing. Here's what we would still recommend. Like, what are you open to? How can we make this more of a possibility for you? And just doing a lot of just really open communication and kind of figuring out that path along the way.
I was going to say too, sometimes when we do have someone in IOP who's struggling, who needs to go to residential and we're not able to find a bed right away, we will maintain them in IOP to provide that support until they go. It's not like they get booted out or kicked out or whatever. That's just something.
Well, everyone, if you could join me in thanking our panelists for their time and their thoughts today. Time out of your busy schedules to come and share this information with hopefully the audience that will get to hear audio. We will see how that product comes out at the end. But also thank you everyone for sitting in and being able to hear the panelists' thoughts. So initially, or rather just to summarize everything, we've covered the full picture about outpatient services, what to expect, what's involved, and then also what I hope is an assurance to the community members as well as other providers who might be hitting that brick wall over and over again, is that there is quite a network of local experts who are here to provide these services, to help people get connected to the ones that they are best fits for. And we just want to thank you again for sharing your time, for sharing your wisdom. And thank you, audience, for being a part of this series. Our next series is next Tuesday, September 30th. If you weren't prepared for it to be almost October, I'm very sorry to burst your bubble. But that's going to be here in this room at 2 p.m. You're welcome to come for yourself, or a loved one, for a client, and then bring whoever you want to bring. But that is all.
What's the topic?
Oh, the topic, yes, thank you. The topic is called I'm in Recovery, Now What? Building a Foundation for Lifelong Recovery. So if you have folks who've got questions about it, we will happily bring them into the fold here next Tuesday.